Hello everyone. Today we'll be discussing role of bronchoscopy in managing secretions and atelectasis. As a non-pulmonologist, you must have asked for bronchoscopy for clearing secretions more than once, and as a pulmonologist, I'm sure you would have encountered multiple consults for bronchoscopy for secretion management. And you must have wondered multiple times that lungs do not open to the extent that you want them to be, and many times there would be no change in a chest x-ray or oxygen improvement. Here we will understand the role of bronchoscopy and its limitation in managing secretion and atelectasis, and why do many patients do not improve the way you want them to. The first answer is maybe you made a wrong diagnosis. Maybe the whiteout on the lungs is not atelectasis and collapse, but rather you are dealing with consolidation and effusion. These conditions can coexist and sometimes difficult to distinguish on chest x-ray. As previously discussed, consolidation, collapse, and effusion appear white on chest x-ray. In consolidation, air is replaced by water, pus, dead cells, or blood. In collapse, the air is absorbed, so the alveoli are deflated, for example in mucus plugs. And in effusion, air is pushed out by extrinsic compression. So in consolidation, the lungs retain their shape. There is no change in position of heart and trachea. You might be able to see air bronchograms, and the rib spacing is normal. In collapse or atelectasis, lungs are collapsed and small. They pull the heart and trachea towards them. There are no air bronchograms, and the ribs appear crowded. In effusions, the lungs are collapsed but are replaced by fluid, so heart and trachea are either in normal position or maybe either pushed away. Air bronchograms may or may not be present. The ribs appear normal, and there may be meniscus present. So in this x-ray, you don't see any air bronchograms, no pulling or pushing of the mediastinum, and it's difficult to assess pleural effusions. So differential include pneumonia with mucus plugging. There may be a component of effusion as well, but it's difficult to tell on the x-ray. For this, just do a bedside ultrasound and that should rule out the pleural effusion. On a CT chest, lungs will retain their shape and you will see air bronchograms. In atelectasis from mucus plug, you will see loss of air bronchograms and the lungs appear collapsed and the rest of the lungs look hyperinflated. In atelectasis from extrinsic compression, you might be able to see air bronchograms and presence of pleural effusion, and the lungs do not retain their shape because the air has pushed out. Sometimes these three things can coexist. For example, in this picture, you see loss of air bronchograms, lungs do retain some of its shape, and there is a presence of pleural effusion. So this patient possibly has consolidation plus component of atelectasis from mucus plugging and or extrinsic compression. This is how the lungs look when they're compressed by pleural effusion. As you can see, lungs are mostly air, so there is a very small amount of tissue that comprises the lung tissue. If you see more tissue than this, you possibly are dealing with consolidated areas. The first scan shows pleural effusion, and you can see the compressed lung secondary to effusion. In the second CT scan, you can see the lungs have retained their shape and you see air bronchograms. So this is showing you consolidation, which is seen in pneumonia. The third CT scan shows that the lungs partially retain their shape. You can see some air bronchograms and presence of effusion. So in this case, you're dealing with atelectasis from effusion, and there's also an element of consolidation. So this CT scan possibly represents pneumonia with parapneumonic effusions. To differentiate consolidation from collapse from mucus plug, look for the shape of the lungs and air bronchograms. Presence of air bronchograms and lungs maintaining their shape shows you consolidation, and if they do not retain their shape and there are no air bronchograms, it is suggestive of atelectasis from mucus plugs. Sometimes both of these can coexist. For example, the CT scan in center, where the lungs do retain some of its shape, but you don't see any air bronchograms. The second reason that your lungs did not expand after bronchoscopy is that the whiteout of the lungs was not from atelectasis from secretion, but from something else that bronchoscopy could not correct. And as we discussed in my previous lecture, there are 4 underlying pathophysiological causes for atelectasis: decreased transpulmonary pressure, if your absorption in alveoli is more than the ventilation, loss of surfactant, and pressure from surrounding tissues. And most of these conditions, except secretions, do not respond to bronchoscopy. In normal alveoli, your ventilation is much more than the absorption. However, as your bronchi gets plugged with secretions, your ventilation to the alveoli decreases and the alveoli tend to collapse. And in case of complete obstruction, you will have no ventilation and all the air is going to be absorbed and the alveoli become atelectatic. So bronchoscopy can only help when secretions are the reason for atelectasis. However, this gets a little bit more complex than this. So question is, how much secretions can you remove from the lungs, or how deep can you go with the bronchoscope? This is what a tracheobronchial tree looks like. There are possibly 10 more order of bronchi not depicted in this figure, but you can see the complexity of it. Using bronchoscope, you can only access till 4th order bronchi. So what you can clean up with bronchoscope is only the proximal areas. You cannot remove secretions from peripheral airways with bronchoscopy. You can sometimes do a BAL that will get you a little bit more secretions from distal airways. However, that is usually not adequate. So that means that lungs will open after bronchoscopy only if there was only central secretions obstructing the airways. Once you get central mucus plugging, the air in the peripheral airways will get slowly absorbed and the lungs are going to become atelectatic. And as you remember from the previous lectures, nitrogen is the one that keeps your alveoli inflated. An alveoli with 100% oxygen deflates in few minutes as compared to the one full of air. So nitrogen acts as a stabilizing agent. So theoretically, if you act early, you may be able to remove central secretions and prevent atelectasis from occurring. Once atelectasis occurs, you have a completely different set of problem, and removal of the secretions, while helpful, will not achieve open lungs. Another thing to consider is the secretions coming from proximal areas. For example, if you have aspirated, you may be able to bronch and clear them out and improve aeration of the lungs. While if the secretions are coming from the distal areas, for example in pneumonias, ARDS, you may be able to bronch and clear them, but cannot improve the aeration of the lungs. This is unfortunately more common scenario. Once atelectasis sets in, the lungs will look white, and recruitment of these alveoli would be the treatment and not bronchoscopy. And if there are secretions present in peripheral airways, recruitment unfortunately would not be easy. So is there a way to know if the lungs will not expand? You can look at the CT scan or chest x-ray, and presence of air bronchograms tells you that there is absence of proximal secretion. That means the secretions are present more distally and will not be amenable to bronchoscopy. These have been associated with longer duration of atelectasis. So why don't lung expand after secretions are removed? First, you cannot go deep enough. You can only access the proximal areas. Second, the distal airways may still have secretions and can remain atelectatic. And third, once atelectasis occurs, there are multiple other reasons beyond secretions that come at play. And fourth, the distal areas may have other problems like consolidation, which will not expand. Unfortunately, there is only one randomized controlled trial on this topic. This is a 1979 study by Marini et al. They compared initial bronchoscopy with respiratory therapy and respiratory therapy without initial bronchoscopy. And you can see the outcomes were pretty similar. The other interesting thing that they reported was presence of air bronchogram did not respond to bronchoscopy, but did respond somewhat to chest physical therapy. This is a great review of bronchoscopy for atelectasis in ICU. I would encourage you to read this article. The bottom line of this review was success rate of bronchoscopy to improve chest x-ray and SATs range between 19 to 89%. Those with lobar atelectasis respond better, and adding BAL to your bronchoscopy may help oxygenation. However, these conclusions are drawn from observational studies, and none of these compared airway clearance therapies. There are not much newer studies after this. There are a couple of observational studies which are unfortunately of very poor quality. Please look at the references if you want to review them. The only guidelines on this topic comes from British Thoracic Society for flexible bronchoscopy, and there is a grade day recommendation for bronchoscopy in specific circumstances in atelectasis. For a much more detailed and skeptic review, you can review these 4 articles. That should give you a good idea where we stand on role of bronchoscopy in atelectasis and secretions. So what can you do to help your patient? Well, if your lung did not expand, you know that you are dealing with atelectasis and or peripheral airway secretions. So manage the quality of secretions and use sputum mobilization technique as we discussed in previous lecture, and that would include chest percussion therapy and posture, vest therapy, intrapulmonary percussive ventilation, and bias flow. Once sputum mobilization gets your secretions from peripheral to central airways, perform suctioning and cough augmentation to get these secretions out. You may require to do some deep suctioning. So for the best results, optimize secretions if needed. Use distal airway clearance therapies and proximal airway clearance therapies together after you perform bronchoscopy. So looking at it visually, if you have got a whiteout of the lung, perform a bronchoscopy, get rid of proximal secretions. That should open some part of your lungs. Performing only regular suctioning after this or just cough augmentation will not achieve anything because the secretions are much more distal, and since there is no air behind these secretions to push them out, you will suction or cough out nothing and the area will remain atelectatic. So use sputum mobilization techniques to get these secretions from distal to proximal airways and perform suctioning and cough augmentation to remove it. Use your atelectasis management techniques to recruit those alveoli. Once you have cleared central secretions, repeated bronchoscopies are no better than airway clearance therapy and suctioning. So overall, bronchoscopy may be useful if you see a complete or near complete lung collapse, significant hypoxemia from secretions, proximal airway obstruction, and acute mucus plugging. The purpose of this video was not to suggest not to perform bronchoscopy, but to understand what to expect and what to do next to take better care of your patients. So in summary, perform bronchoscopy, clear the central secretions, figure out if patient needs mucolytics. If you want to perform BAL in that area, that may help you clear off more secretions. If the lungs open up, use atelectasis prevention tools. If lungs don't open up, use distal and proximal airway clearance therapies. Usually repeated bronchoscopy are not needed. If you see air bronchograms on chest X-ray or CT scan, bronchoscopy will likely not help you open up the lungs. For details about atelectasis and secretions, watch my lecture on these two topics. I think you will find them very useful. This is a cool website called openai.com, DALI 2, in which if you put in some search term, the AI is going to generate an interesting image which you can use for your presentations. Thank you.